Chronic pain after limb amputation is a significant challenge for many patients. Up to 85% of amputees experience painful neuromas, phantom limb pain, PLP, or residual limb pain, RLP. These conditions can severely impact quality of life, making daily activities and prosthesis use difficult. In recent years, new surgical techniques have emerged to address these problems, aiming to improve both pain and function for amputees. Today, we'll explore the latest evidence comparing targeted muscle reinnervation (TMR) with standard peripheral nerve management (SNT) after amputation, and what this means for patients and clinicians. Targeted muscle reinnervation, or TMR, is a surgical technique designed to restore lost motor control information after amputation. Surgeons redirect residual nerves to new muscle targets, providing a physiologically appropriate environment for nerve regeneration. This helps prevent the chaotic nerve growth that leads to painful neuromas. Originally, TMR was developed to improve control of advanced prosthetic limbs, but it's now recognized for its role in reducing pain. By connecting nerves to denervated muscles, TMR can help organize nerve regrowth and reduce the risk of chronic pain syndromes. Standard neurological treatment, or SNT, is the traditional approach for managing nerves during amputation. This may involve traction neurectomy or burying nerves into muscle or bone. While these methods aim to reduce pain, they don't always prevent the formation of painful neuromas or phantom limb pain. As a result, many patients continue to struggle with chronic pain after amputation. The search for better solutions has led to increased interest in alternatives like TMR. Recent systematic review and meta-analysis set out to compare TMR and SNT in amputee patients. Researchers searched major medical databases for studies comparing these two approaches, including both randomized trials and cohort studies. They focused on adult patients who had undergone upper or lower limb amputation for any reason. Outcomes assessed included pain scores, opioid use, functional outcomes, and the development of neuromas. The review followed rigorous guidelines to ensure the quality and reliability of the findings. Review included 11 studies with a total of 1,117 patients. Of these, 216 received TMR and 708 underwent SNT. 5 studies specifically compared primary TMR, performed at the time of amputation, with secondary TMR, which is done later if needed. Studies covered a range of patient populations, including those with significant comorbidities such as cancer or diabetes. This broad inclusion helps ensure the findings are relevant to real-world clinical practice. Measure pain outcomes. The studies used validated tools such as the Patient-Reported Outcomes Measurement Information System, PROMIS, the Numerical Rating Scale, NRS, and the Visual Analog Scale, VAS. These tools help quantify the intensity, behavior, and interference of pain, making it possible to compare results across different studies and patient groups. By using standardized measures, the review provides a clear picture of how TMR and SNT affect pain after amputation. Phantom limb pain, or PLP, was a primary outcome in 7 of the included studies. The meta-analysis found that patients who received TMR reported significantly lower PLP scores compared to those who had SNT. This was true across multiple pain measurement tools, including PROMIS and NRS. The reduction in pain was not only statistically significant but also clinically meaningful, suggesting that TMR can make a real difference in the lives of amputees struggling with phantom pain. Residual limb pain, or RLP, was also assessed in several studies. The meta-analysis showed that TMR led to lower RLP scores compared to SNT, again using PROMIS and NRS tools. Patients who underwent TMR were less likely to rate their pain as severe, and more likely to experience meaningful relief. These findings reinforce the potential of TMR to address multiple types of post-amputation pain, not just phantom sensation. Painful neuromas are a common complication after amputation, caused by disorganized nerve regrowth. 2 studies in the review specifically looked at neuroma formation and pain. Both found that TMR reduced the frequency and intensity of neuroma symptoms compared to standard treatment. Most patients who received TMR, whether primary or secondary, were free of neuroma pain at final follow-up. This highlights another important benefit of TMR for amputees. Beyond pain relief, improving quality of life and functional outcomes is a key goal for amputee care. 2 studies reported on these outcomes. One found that patients who received TMR had higher NEU or OQL scores, indicating better quality of life. Another study showed that TMR patients were more likely to be ambulatory after surgery compared to those who had SNT. These improvements can translate into greater independence and satisfaction for amputees. Managing pain after amputation often involves opioid medications, which carry risks of dependence and side effects. 4 studies in the review assessed opioid use. TMR patients showed a significant reduction in opioid consumption compared to those who had SNT. In some studies, over 80% of TMR patients were able to stop using opioids by the final follow-up. This suggests that TMR not only improves pain but also supports safer, more sustainable pain management strategies. Important question is whether TMR is more effective when performed at the time of amputation, primary TMR, or later secondary TMR. The review found that primary TMR resulted in significantly lower postoperative pain scores compared to secondary TMR. Patients who had TMR during their initial surgery were more likely to be pain-free and required less opioid medication. Although more research is needed, these findings support the use of TMR as a proactive strategy during amputation. Reductions in pain scores with TMR were not only statistically significant, but also exceeded the minimum clinically important difference, MCID, for the pain measurement tools used. This means that the improvements are likely to be noticeable and meaningful for patients. The findings were consistent across different types of pain and measurement scales, strengthening the case for TMR as a valuable intervention. Many patients who undergo amputation have significant comorbidities, such as cancer or advanced diabetes. The review found limited but promising evidence that TMR can benefit these high-risk groups. In one study, TMR patients with multiple comorbidities were more likely to be pain-free and ambulatory compared to those who had SNT. However, more research is needed to fully understand the risks and benefits of TMR in these populations. While the findings are encouraging, the review also highlights some limitations. Only a few studies were suitable for meta-analysis, and most were retrospective cohort studies rather than randomized trials. There was also variability in how pain was measured and reported. These factors mean that while the evidence supports TMR, more high-quality research is needed to confirm its benefits and guide best practices. All studies included in the review were conducted according to ethical standards, with appropriate oversight and adherence to guidelines for human research. No conflicts of interest or financial support were reported by the authors. This transparency helps ensure that the findings are trustworthy and relevant for clinical decision-making. Based on the available evidence, experts recommend considering TMR as a valuable adjunct during amputation surgery, especially for patients at risk of chronic pain. Early intervention with TMR may offer the greatest benefits, reducing pain, improving function, and minimizing opioid use. However, individual patient factors and surgical expertise should always guide treatment decisions. Review underscores the need for more research, particularly in highly comorbid patient populations and with longer-term follow-up. Larger, prospective randomized studies with standardized outcome measures will help clarify the role of TMR and refine best practices. Ongoing innovation in surgical techniques and pain management will continue to improve outcomes for amputees. Summary: targeted muscle reinnervation offers significant advantages over standard nerve management for amputee patients. It reduces phantom limb and residual limb pain, lowers opioid use, and improves functional outcomes. Primary TMR performed at the time of amputation appears to be especially effective. While more research is needed, TMR represents a promising advance in the care of amputees. For patients facing amputation, understanding the options for nerve management is crucial. TMR may offer better pain control and quality of life compared to traditional approaches. Patients should discuss the risks and benefits of TMR with their surgical team and consider their individual health needs and goals. Informed decision-making is key to achieving the best possible outcomes. Targeted muscle reinnervation is emerging as a valuable tool in the management of post-amputation pain. By reducing both phantom limb and residual limb pain, improving function, and lowering opioid use, TMR has the potential to transform the lives of amputees. As research continues, patients and clinicians alike can look forward to more effective, evidence-based approaches to amputation care.